Hey everyone, good afternoon. Thank you for joining us today. If you are in the STI Masterclass Virtual Training number 2 for testing and treatment updates, you're in the right place. This training is hosted by HCET with our two presenters today, Dr. Jessica Dalby and Dr. Laurence Moore. So my name is Adele White. For those of you who haven't met before, I'm a project manager here at HCET, and I will be moderating the webinar today. So just before we get started, we go over a couple of things. I'm just going to introduce you to healthcare education and training. I'll call it HCET for short. So HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education and training and care is a fundamental right. And will you go to the next slide, please, Dr. Dalby? So this webinar does have closed captions available. You can enable them on your screen by clicking live transcript and then show subtitles, and you can change the subtitle settings as well by clicking subtitle settings. And then next slides, please, Dr. Dalby. And with this webinar type, you can ask questions in the chat. I will leave them until the end for us to answer them, just so we have time to get through everything, but you can put questions in the chat as we go. So just put them in as you think of them. And then following this webinar, there will be a link sent to you with an evaluation. It really, really helps us if you fill out the eval for us to improve our trainings in the future. And then also, if you are collecting nursing contact hours for this, you'll need to fill that out as well. Oh yeah, there's the slide about nursing contact hours. So after you complete the eval, also email my coworker, Kelly Bradford, and she will also have a sheet for you to fill out for nursing contact hours. So kbradford@hcet.org is who you contact for nursing contact hours. Let's see. And this presentation will be archived on our website at hcet.org, so you can go to find that if you're not able to listen to the whole thing or anything. And if you have any tech difficulties during the presentation, shoot me an email at awhite@hcet.org. All right, I am super excited to introduce our presenters. Oh, one thing I always forget, no one with the ability to control content of this activity has relevant financial relationships to disclose. So our presenters today are Dr. Jessica Dalby and Dr. Laurence Moore. Dr. Dalby earned her medical degree in 2008 from Baylor College of Medicine in Houston, Texas, and completed a family medicine residence at the University of Wisconsin-Madison right here in our state in 2011. She went on to complete an academic fellowship within the UW program prior to joining the UW faculty in 2012. And in 2017, she became the medical consultant for sexually transmitted diseases within the City of Milwaukee Health Department. So many of you know this large urban health department faces high rates of sexually transmitted infections and a sharp resurgence of syphilis more recently. Dr. Dalby is currently developing a syphilis-specific continuing medical education to address the Wisconsin syphilis resurgence in collaboration with UW-Madison Interprofessional Continuing Education Partnership. Her other teaching and academic interests include reproductive health and prenatal care and obstetrics. Also with us today is our fellow presenter, Dr. Laurence Moore. He's the American Medical Association Foundation LGBT Medicine Fellow in the Department of Family Medicine and Community Health at the University of Wisconsin-Madison. He attended med school and completed his family medicine residency at Oregon Health and Science University in Portland, Oregon, before beginning his LGBT medicine fellowship. Before that, he also worked in primary care at a federally qualified health center. He loves applying public health principles to medical practice and finding ways to advance high quality and equitable care. In his spare time, he enjoys reading, travel, and learning new languages. So I'm very excited to turn things over to Dr. Moore to get us started. So yeah, there we go. I will mute myself now, and feel free to put questions in the chat.
All right, so hello everyone. It's nice to meet you. We have a lot of material to get through today. If we review our learning objectives, we're going to review some most recent guidelines for screening and treatment of some different STIs, hopefully develop an approach to evaluate and treat non-gonococcal urethritis, and then at the end, we'll have some slides to talk about expedited partner therapy here in Wisconsin. So I have no disclosures, and Dr. Dalby also has no disclosures. Let's get into our first objective. So our first objective is reviewing most recent screening and treatment guidelines for different STIs. And we're going to start with a case. So in this case, our patient is Liz. She's a young female patient referred from urgent care for follow-up of STI testing. You find on physical exam a labial ulcer, and some labs that were drawn at the urgent care have a positive treponema antibody test with an RPR titer of 1 to 32. You don't have any prior RPR titers available, and a pregnancy tested negative. So the question here is, how are we going to treat this patient? And if you can take a minute to answer this question, we will see what people think. How are we doing for responses? Okay, so we have a lot of A, a number of B, and then some C. Okay, so before we dive into the answer, let's talk about syphilis, and then we'll come back to the answer. So if we go to the next slide, so we know that in Wisconsin and nationally, syphilis rates are increasing. This was the focus of the first webinar, so we don't want to go into this too much, but syphilis rates are increasing at an alarming %, and then congenital syphilis rates are unfortunately increasing as well. Who needs to be screened for syphilis? So the USPSTF recommends screening for all people who are at increased risk, and then all pregnant patients early in pregnancy. In addition, the CDC further recommends at least annual screening for men who have sex with men, people living with HIV, and transgender people. One question is, who do we think of as people who are at increased risk? The USPSTF, which is the United States Preventive Service Task Force, defines this as men who have sex with men, people with HIV, people who use drugs, people who have been incarcerated, people who are employed with sex work, or interestingly, people who have military service. They also specify that clinicians should be aware of how many syphilis rates are, what syphilis rates are in their local jurisdiction, and kind of use clinical judgment. So if you think that syphilis rates are high and you think someone's at risk, test liberally. Okay, so next, that's the CDC recommendation. So here we're talking about screening and testing for syphilis. So we have different tests for syphilis. We have the RPR test, the VDRL, and then the treponemal antibody test. And they test for different things. The RPR is a marker of inflammation, which can be specific for syphilis, but can also be elevated in other clinical settings, such as pregnancy. The treponemal antibody test is a little bit more specific for syphilis, but it has, and it is positive earlier on in the course of infection. So what we currently recommend, and what some different labs are doing, is to combine these two tests into a single algorithm. This is called a reverse sequence algorithm, because instead of testing the RPR first, you're testing for the treponemal specific antibody first. And so by starting with that test, then the next cascade, if that test is positive, is to check the RPR. And then if that is positive, that's a definite case of syphilis. If it's negative, however, then there's one further treponemal test that can be done to further clarify if someone has syphilis. This testing algorithm should be read with some caveats. In high prevalence and low prevalence settings, we have to interpret tests differently. So if syphilis is low prevalence, then if we're doing a treponemal antibody assay, we would expect to have more false positives than in a very, very high prevalence setting. So something to be aware of is that interpreting the RPR together with the treponemal antibody assay result is really important. Also, the timing of the exposure, the timing that someone is getting a test is very important. It is possible, even though the antibody will be positive before someone may have a positive RPR, it is possible that in the first couple of weeks after an exposure, that the antibody would not yet be positive. So you might want to follow that patient and retest them in a couple of weeks with the antibody test. It is also possible that someone may have a negative treponemal test if they are in an early infection. So again, it's important to think about this testing algorithm in the context of where you are testing them and the person who is showing up in front of you, what their recent exposure was and what symptoms they have.
And I think here, Laurence, just to like kind of harp on the key point here is that, serology antibody tests are really limited, similar to like Lyme's disease that we see a lot in Wisconsin. There is a delay between exposure and positive antibody test. And so again, we sometimes see people who have clinically a chancre that is consistent with syphilis and might have negative syphilis testing. And, often I see clinicians make the mistake of not treating that person for syphilis in their most infectious stage because the antibody tests are negative. So again, empiric treatment, if you think somebody has a chancre, they have risk factors for STIs, we should be treating them.
So moving on to our treatment options. What are our treatment options? So we are used to using bicillin, which is penicillin G benzathine. This is now on a shortage. Hopefully, we're all aware that this medicine should be reserved for the treatment of syphilis and more specifically for the treatment of pregnant women and infants with syphilis. For pregnant women, we don't really have other options. And so that's why we need to keep our limited supply of bicillin for pregnant women who may have syphilis. The alternate treatment, which is now recommended given the state of this shortage, is doxycycline. So for primary syphilis, early syphilis, we can give doxycycline 100 milligrams twice daily for 14 days. For latent or unknown duration syphilis, we would be giving this for 28 days. What is primary syphilis? What is secondary syphilis? So as Dr. Dalby mentioned, primary syphilis, the defining feature is the chancre. May or may not be painful, and can last a couple of weeks before resolving spontaneously. There may or may not also be non-tender regional lymphadenopathy. And like we say, treat with bicillin, just the one shot, or doxycycline for 14 days. Don't forget, you do need to write yourself a reminder to follow up with that patient in 3 or 6 months to follow their RPR, make sure that it's downtrending so that you can be sure that that treatment was successful. How about secondary syphilis?
Yeah, and actually, I'll just step in here. I realized on our slide we forgot to include bicillin LA, so that's the long-acting version of penicillin G benzathine, and that's important to differentiate in our clinical practice from bicillin CR, which might be used, for example, in treating strep, but that's, the CR version is a shorter acting version and does not treat syphilis. So bicillin, and this is important for answering our question, it's the bicillin LA version, the long acting version that's important for treating syphilis.
Secondary syphilis, this is the syphilis that we don't know how long it has been around, and we have to kind of try and do some detective work. And maybe if you can work with your health department to get some RPR titer history, if you can figure out when their last test was or when their exposure was, then that all would be really helpful information. But if you can get that history and you can prove to yourself that the infection was within the last year, then the treatment will be the same, which is that bicillin LA 2.4 million units in one injection, or doxycycline for 14 days if someone is not a pregnant person or an infant. The late latent, if you cannot get that information, if you don't know when the exposure was, if you don't know when the infection was, may have been more than a year ago, that's when we're bringing people back for the bicillin injection weekly over 3 weeks, or in the case of a non-pregnant person, we're giving them doxycycline for 28 days. And again, don't forget, we're following up titers in 3 months and 6 months to make sure that it's downtrending, that we've really treated the infection successfully.
And I think just to in our effort to condense slides and get a lot of information out there, I want to make sure that there's no confusion here. So secondary syphilis is when there is typically systemic signs and symptoms of syphilis. So you can only diagnose secondary syphilis if somebody has a rash, if somebody has mucus patches, if somebody has alopecia. And then, if people have no signs or symptoms of syphilis, so there's no chancre to diagnose primary, there's no skin lesions to diagnose secondary syphilis, then we talk about latent syphilis, which again is just serology and no physical exam findings. And then that's divided into less than 12 months or more than 12 months to help dictate treatment guidance.
So next, there's that rash. Okay, so next we'll just touch on again some of those systemic symptoms, which often are or maybe overlooked. So ocular, oto, and neurosyphilis. It's important when you are seeing someone who you suspect may have syphilis that you are thinking about this in the back of your mind. Don't forget that there can be ocular manifestations of syphilis when it does get to that secondary degree. So for ocular syphilis, you'd be asking about eye pain, floaters, light sensitivity. For otosyphilis, tinnitus, balance difficulties, dizziness, vertigo. And then for neurosyphilis, that's when you might have meningitis symptoms, cranial nerve dysfunction, maybe tabes dorsalis, some of that vertigo and problem with balance, or an acute altered mental status.
And working with the health department, I would say, often it's a little bit unclear, right? Because sometimes people have, some eye pain, some vision changes, and you're thinking like, how long have they had this? Is this new? Is this related to the syphilis? And I would say a lot of times, again, we really need referral with specialist input and ophthalmologic exam to really kind of narrow this down. And sometimes, we end up just treating presumed neurosyphilis because we can't rule it out. So again, sometimes that is necessary. So just to summarize with our case, so for Liz, again, she had a labial ulcer, which would put her as primary syphilis. She, in our choices, so the first choice, the single dose, so somebody with primary syphilis needs usually just one dose of bicillin long-acting, but that would actually, for Liz, because she's non-pregnant, the preferred choice of the options available was actually the 2 weeks of doxycycline was the correct choice in this case. You don't, current guideline-based treatment would not be 3 doses, 3 bicillin doses weekly. That's usually what we use for latent syphilis. For her, the correct choice was actually the doxycycline. So we're going to move on then to another case. We're going to talk about AJ, who is in your STI clinic today with dysuria and penile discharge, several recent partners with inconsistent condom use. Sexual practices include using his mouth and penis. He does not report receptive anal sex. And at your on-site lab, a slide with a gram stain of the discharge shows gram-negative intracellular diplococci. And so that gives us a presumptive diagnosis of gonorrhea. So in the 2021 guidelines, we see that the monotherapy with ceftriaxone is now recommended, and it is going to be weight-based dosing. So generally, we're going to be treating gonorrhea with 500 milligrams of ceftriaxone IM. But if somebody weighs more than 300 pounds, then to get adequate serum levels of the ceftriaxone, the recommendation is to give a full gram of ceftriaxone. If somebody reports a significant allergy concern, the alternative would be, and our slides got covered up here. The alternative would be gentamicin plus azithromycin. So gentamicin, 240 milligrams IM injection plus azithromycin in a single dose. And again, oral cefixime could be an option if you don't have access to IM. However, oral cefixime really doesn't penetrate the oropharynx as well. So somebody who has oropharyngeal exposure to gonorrhea or test positive, you really want to try for IM ceftriaxone. Again, in settings where you're like in our setting here, if we can't exclude chlamydia on the day that we're treating, we want to treat and cover chlamydia as well, preferably with doxycycline. 100 milligrams twice daily for 7 days. So in our setting, we're going to give this client an IM injection of ceftriaxone, the doxycycline to cover co-infection. And in addition to the urine testing that we're doing today to confirm what we make a presumptive diagnosis based on gram stain, we're also going to swab the patient's throat given that they report oral sex. Why is it important to identify pharyngeal gonorrhea? One, the treatment is generally the same. So again, the goal still is ceftriaxone. And again, what we know here is if somebody has pharyngeal gonorrhea, actually gentamicin is only about 80% effective. Again, cefixime is only about 80% effective for curing pharyngeal gonorrhea. So again, this is especially important for ceftriaxone. But also with the new recommendations, a test of cure is recommended for every patient with pharyngeal gonorrhea. Why? Why is that? So, interestingly, the oropharynx, because of all the other bacteria that are there, the CDC recognizes that this is, has the greatest risk for developing drug resistance and decreased susceptibility. And so, they are now recommending, and also because medication doesn't penetrate the oropharynx as well. And so that's why a test of cure is really recommended for all patients with pharyngeal gonorrhea. And a test of cure different from just retesting. Currently guidelines say that we should retest everybody who has a recognized STI should have retesting after 3 months. And really that's just looking for reinfection. But a test of cure is really making sure that the gonorrhea that you think is there is cured by your treatment. And so that's not routinely recommended, but in anybody who has pharyngeal gonorrhea, you would want a test of cure. Anybody who has persistent symptoms, so has suspected treatment failure, should also be retested. If somebody had gonorrhea and was unable to be treated for some reason with recommended regimens, so occasionally I see people with random allergies that get treated with Cipro. We know there's a lot of resistance to Cipro. That person should have a test of cure. And in some labs where they have access to antibiotic susceptibility testing and culture, if there was any sign that there was a decreased antibiotic susceptibility, you want to get a test of cure in that person. So when should we get a test of cure? It's a little bit complicated in how we do test of cures and when we do test of cures, because our NAT tests, our DNA tests are so sensitive that they are potentially detecting both live and dead organisms, right? So if you repeat NAT testing too early, you don't know if somebody actually has a persistent infection or if they just have remnant DNA from a treated infection. So anybody who has persistent symptoms and presents less than 7 days from treatment, that is too early to get a NAT. You really have to get culture in that case. Some of our clinic and lab settings have the option to do culture. If your setting doesn't have the opportunity to do culture, this is where coordination actually through the state health department is really important to access culture-based testing for your clients. And this is a huge push right now for us to be tracking and looking for cases of resistant gonorrhea. Gonorrhea over time has become resistant to every form of antibiotic that we've used for it. And so in our lifetime, in our practice lifetimes over the next 10 years or so, we will expect to see increasing rates of ceftriaxone resistance. And so currently there are protocols being implemented to really be looking for this. So again, suspect treatment failure, persistent symptoms after treatment. And again, I would say, always, if somebody has persistent symptoms, the first question is always like, are they reinfected? But again, if they're returning less than 7 days, you really need a culture. If somebody is between 8 and 13 days returning for this test of cure, vaginal, rectal, and penile gonorrhea actually clears fairly quickly, and usually by 7 days, NATs should be negative. So between 8 and 13 days, if it was a anogenital site, again, you can repeat NAT testing at that time and rely on those results. But the oropharynx, the note here is just like the oropharynx is slower to clear remnant DNA from adequately treated gonorrhea. And so really for oropharyngeal gonorrhea, which often doesn't have any symptoms, but again, you really don't want to repeat a NAT test in the oropharynx until it's been at least 14 days, because again, you can get a positive NAT, and what does that really mean? We don't really know then if that's remnant or not. So this is kind of an introduction today to some of these treatment table and algorithms that will eventually be available also through the State Department of Health Services website in kind of a finalized form. But I wanted to give people a kind of a sneak peek of these. Again, we're talking about a little bit about suspect treatment failure. So again, if somebody has symptoms lasting for after they've been treated, symptoms should be resolving within 3 to 5 days. If they were continuing to have symptoms after that point, then you need to reassess, like, is reinfection likely? Again, most people will be reinfected, but we are trying to keep an eye out for emergence of drug-resistant gonorrhea, which again, we are going to start to see. So if reinfection is likely, then we need to, retreat them for gonorrhea. But if somebody says, I really haven't had sex, there's just no way, then the next step is really thinking, like, have we ruled out other infections? Did we make sure to rule out both chlamydia? And if somebody has persistent symptoms, this is where we're thinking about Mycoplasma genitalium. So again, this will help us know, like, again, are there other infections should we be thinking about? And really, if reinfection is unlikely and somebody is still having symptoms and doesn't have other co-infections, this is where we really need to get, again, a test of cure, and we really want to be thinking about getting a culture for antibiotic susceptibility testing.
Okay, so we are going to move forward into thinking about screening and who do we screen for what. So here is a case, just a general patient who shows up to primary care. They're getting back into the dating scene. They want to be tested for different STDs. They don't have any signs or symptoms. They're otherwise healthy. So our question is, what are you going to test this person for? So we're going to look by different diseases, and we're going to start by thinking about HIV. Who do we screen for HIV? So the USPSTF is recommending that we screen all patients, all adults 15 to 65, and all pregnant persons for HIV. And the CDC's recommendation is similar, although a little bit different. The age range from the CDC is 13 to 64. I don't have any particular insight as to why that age range is slightly different. They do recommend an opt-out approach. So when you are discussing this screening with a patient, recommending, we screen everyone for this disease, the government and the CDC, both and the USPSTF all recommend that everyone gets screened for this. If you wouldn't like to be screened, let me know, but kind of taking an approach that everyone should be screened. The CDC also recommends screening pregnant people at their prenatal care, and then also those seeking STI evaluation, and then MSM at least annually for sexually active men who have sex with men. Next, we're thinking about syphilis, and we were just thinking about syphilis, but just to reinforce once again, the USPSTF is recommending screening everyone who is at increased risk, and also pregnant people who are early in their pregnancy. And the CDC recommends that, and in addition, recommends at least annual screening for syphilis for men who have sex with men, people living with HIV, and transgender persons. The next one is genital herpes. So we have serologic screening, and then we have symptom-based screening. So serologic screening is the blood test for antibodies to HSV1 and 2, and symptomatic screening is swabbing a lesion that you see on someone's penis or on someone's vulva or elsewhere on someone's body. For serologic screening, and maybe this used to be a common practice, but the USPSTF now recommends against routine serologic screening for herpes in asymptomatic adolescents and adults. It seems like some people out there are still doing this, so it's important to realize that the antibodies are really widespread. A lot of people have been exposed to HSV in the course of their lives, and so they will be positive for these antibodies. The CDC has a bit more nuanced of a recommendation. They say that the serology test can be considered in certain situations. For example, If someone has multiple sex partners and they want to know if they may have this disease, that may be something that you can do for them. If they are in a relationship or getting into a relationship and they want to know if they and their partner both have or may have been exposed to this virus in the past, then it's something that can be considered. For people with living with HIV, that's a group of people who have some immune suppression. So the CDC says that should be considered when someone living with HIV presents for an STI evaluation. But this is a pretty nuanced discussion, and you want to be having it on a case-by-case basis with your patients. It's not something that the guidelines really suggest should be included in routine screening for all people who have no symptoms. Okay, and next is chlamydia screening and gonorrhea screening. So here, the USPSTF recommends selective screening of women for young women, 24 years and under, annual screening, and then for women 25 years or older, people who are at an increased risk of infection. And then also, we want to be screening people who are pregnant and meet those same criteria. I would add that the CDC does have some pretty nuanced guidelines for gonorrhea and chlamydia screening, and they differ by group of persons. So if you look on the CDC websites, and let's say you're dealing with a young woman who has some increased risk factors, then the CDC guidelines will tell you in which cases you should be screening that person. Or you have a man who has sex with man, and that's your patient, then the CDC guidelines have specific criteria and how often you should be screening that person. They're pretty nuanced, and they go into a lot of detail. I couldn't fit it down into one slide, so my apologies. But if you're in a situation and you need to look up, they're very easy to look up on the CDC website. So the next one that we're going to talk about is hepatitis B. And this is something that has been updated in the recent past. The USPSTF is recommending screening for people who are at an increased risk of infection and pregnant women in their first prenatal visit. And then the CDC is also recommending people who are at an increased risk of infection, pregnant women, and all men who have sex with men and people living with HIV. The definition of who is at increased risk for infection with this is different if you're looking at different sources. But suffice it to say that if someone was born or lived in a country that had high prevalence of hepatitis B, or if they're born to people who lived in a region that meets that description and they didn't get their hepatitis B vaccine at birth, or they have HIV, or men who have sex with men, or people who have IV drug use and may share needles, those people are all at increased risk. The CDC's guidance is a little bit different, but it's somewhat similar. I think the move here is towards more screening of more people for hepatitis B. It is a treatable, controllable disease, and it is reasonably prevalent, and that's one reason why we want to be making sure that kids are vaccinated as young as they can be, and that we are screening all people who are at increased risk.
And also vaccinating those at risk for STIs showing up in our clinics as well if they're not vaccinated. You know, new vaccination recommendations are really to offer that for everyone who hasn't been previously vaccinated.
Absolutely. So I think we're doing okay for time. We have some cases now. So here we have, let's say you are seeing in your clinic a 23-year-old cisgender female. She's getting back to the dating scene. She wants to be tested. She has sex with male partners, and she uses her vagina and throat for sex. So what do you test for? That is our question. Okay, so there's our poll. So go ahead and answer if you can. For this young cisgender female who has no symptoms, what would you test for? Okay. Can we see the answers? Okay, great. So the learning point here is we're not testing for HSV serology in someone who has no symptoms. We definitely want to be testing for gonorrhea and chlamydia. And if someone is using their throat for sex, then we want to be swabbing their throat. So we suggested that be the correct answer. Our next case is a 32-year-old male who you see in the primary care setting. They have no signs or symptoms, but they're getting back on the dating scene, has sex with male partners and uses his penis, bottom, and throat for sex. So in this patient, what would you test for? And there's our poll. We'll give you a minute or two to answer. Okay, let's see the responses if we can. Okay, so that's correct. So the answer is triple site screening. So the learning point here is that we are doing triple site screening for men who have sex with men. And let's see, our next case is a young, oh.
I think we cut that one in the name of
Oh, okay,
time.
we cut that
So,
one. Oh, sorry. Okay, go ahead.
all
Go
right.
ahead.
Lucky me, we are going to jump back into talking about more penile discharge. All right. So in this case, we're seeing Alan, a 24-year-old male patient, again, dysuria, mucoid discharge, sexually active with both male and female partners, not using condoms, but denies any previous STIs. And on exam, there's discharge, no ulcers. You collect a routine set of labs. But in the meantime, for today, are you going to empirically treat, report the case to our local public health department, discuss and offer partner services, including notification and EPT, or empirically treat with ceftriaxone and azithromycin versus ceftriaxone and doxycycline? So actually just to keep us moving, we will just kind of, instead of audience polling, we'll just talk through this. Really the answer is any and all of the above. When we think about our empiric treatment, the most important treatment for this case, while in an STI clinic, often we might have options to look at the discharge on a slide, but many of our clinical settings, we don't have that opportunity to be gram staining at a point of care. So often we're waiting for results, but the person who's having symptoms, we're typically treating this empirically. And so covering both gonorrhea and chlamydia is important. Typically, we have evidence now that doxycycline is a little bit better at rectal, actually not a little bit, a lot better at covering rectal chlamydia. So doxycycline is going to be ideal. However, it also requires somebody to adhere to that regimen, to a 7-day course. So there are certainly times, and azithromycin 1 gram is an alternative that's acceptable. Again, it's going to be best at treating penile symptoms, not as good as treating rectal symptoms of chlamydia. But again, these are things that are going to be important to both think about expedited partner therapy and of course, reporting to public health these type of communicable diseases is important as well. So what do we know about urethritis? Again, urethritis is any condition that's causing urethral inflammation. So sometimes that's infectious with bacteria, sometimes it's viral, and sometimes it's irritants can also cause urethral inflammation. Typically people are presenting with symptoms of dysuria, sometimes itching, and often discharge as well. It's more common in men, but also seen in women, typically in younger ages. The people that are most affected by gonorrhea and chlamydia tend to be, again, people under the age of 25, and then those who have unprotected sex or multiple partners. An interesting study out of Japan really broke down all of the many causes that they were finding for urethritis in, this was an STI clinic population out of Japan. And you can see in their high-risk population in an STI clinic, about 70% of people had either gonorrhea or chlamydia. You can see about 10% of this population had MGen. There was a little bit of mycoplasma, hominis, and ureaplasma. But there's also, other bacteria that we don't typically look for, like Haemophilus influenza, Neisseria meningitidis. There was actually several viral causes. So adenovirus, AV here stands for adenovirus, and 6% of patients had adenovirus causing their symptoms. Again, these are not things that we're typically testing for. Herpes certainly can cause that. Trichomonas can cause some symptoms. But in this population, a high-risk population for STIs, there was about 7% of cases where they didn't detect that, there was no detectable pathogen that we were testing for, right? So again, there can be a number of different causes of urethritis. At the Milwaukee Health Department, we looked at our data back in 2019 is when we first introduced testing for Mycoplasma genitalium. And at that time, anybody who presented with urethritis at the initial visit was tested for gonorrhea, chlamydia, trichomonas, and MGen. And we found in the first 6 months, we saw about almost 800 male patients with urethritis symptoms. And the most common cause in men presenting with symptoms was gonorrhea, but the second most common cause was Mycoplasma genitalium, and that was a little bit more prevalent than chlamydia. Now, when we look at these infections, half of the MGen infections involved co-infections, and we're going to talk about this a little bit more, but MGen is really prevalent, and if there's co-infections, what's causing the symptoms? Is it the trichomonas and or is it the MGen if you have a co-infection? Is it the gonorrhea or the MGen when you have a co-infection? So we were finding a lot of MGen. Whether that was always causing the symptoms, hard to say. But, also I will, just point out here that because there was so many co-infections here, there was about half of the patients had no identifiable or STI organism collected. So again, a number of patients presenting with urethritis we did not identify a cause for. So in our case, you're following up your labs, and both gonorrhea and chlamydia came back negative for this person. So we're trying to figure out, okay, well, we treated them for gonorrhea and chlamydia, and they don't have that. So what's causing their symptoms? Depending on your health system, a lot of times, if you didn't originally think about trichomonas, you could think about adding on sometimes a trichomonas gnat to the sample already collected. But a lot of times calling the patient and find out, how are they doing? Are they still having symptoms or not? We're not able to reach our patient, right? So then you get a my chart 10 days later saying, yes, he is still having symptoms. So then we want to know, again, is this somebody who has been, have they had any new exposures between now and then? That's always the first question. Are there new exposures? Were they able to complete their doxycycline? Did they actually complete it? And, the new recommendation for Mycoplasma genitalium with the 2021 STI guidelines from the CDC is that for people who have persistent or recurrent urethritis symptoms, that's when we should now be testing for Mycoplasma genitalium as well. So more about Mycoplasma genitalium. It is common in the general population. Estimates, are varied, but some estimates say the general population might only be 1 to 2%. In an STI clinic, the rate can actually be much, much higher. Testing really became widely available in 2019 when the widespread availability of PCR testing became available. It was really hard to culture MGen before this, so it was really hard. It was often, again, one of those urethritis cases that we couldn't find a cause for. But with the onset of MGen testing in via PCR in 2019, we see this being available in most clinical settings at this point. Similar to chlamydia, the ideal testing in somebody with a penis would be a first void urine, and somebody with a vagina would be a vaginal swab. Treatment is actually rather limited. So, because there's no cell wall, penicillin and cephalosporins don't work. Best evidence at this point shows that doxycycline, while it doesn't cure MGen, it actually kind of weakens MGen and reduces the bacterial load, so that then azithromycin or moxifloxacin can actually eliminate or cure the disease. Really, azithromycin use may be limited because of increasing macrolide resistance. And in many countries, macrolide resistance testing is routine. I would say that's not widely available to many of us in our clinical settings. And so again, that really limits the use of azithromycin. And so again, typically treatment then, if you had testing available, you might use that to guide the basis of using azithromycin or moxifloxacin. But, for most of us, we don't have that. And so for most of us who are trying to treat MGen, we're talking about 2 weeks of antibiotics. So doxycycline for 7 days, followed by moxifloxacin for 7 days. So, this, again, Mycoplasma genitalium is a little bit the bane of my STI consulting right now and for the last several years, because it's so difficult to treat. We're seeing, again, growing antibiotic resistance. So especially in high-risk populations, in studies of MSM, for example, they've shown that there's up to 80% macrolide resistance. And we're seeing increasing moxifloxacin resistance emerge as well. And we don't have other good treatment options at this point. So again, the limited treatment options that there are can cause some toxicity. So can have, can cause quite a bit of symptoms. And again, actually, there's no good options for pregnant patients. You can't use moxifloxacin in pregnancy. You can't really use doxycycline in pregnancy typically. So that only leaves you with a high dose azithromycin course, which, as we just talked about, is probably not that effective. So again, some guidelines really talk about, weighing risk and benefit of trying to treat your pregnant patient, for example. And again, what is the effect of a long antibiotic course on the microbiome? And really, if you have more than about a 2-week lapse between giving doxycycline and somebody getting treated with moxifloxacin, you should probably repeat it. Because again, the goal of the doxy doesn't eliminate Mycoplasma genitalium, it just weakens it so that the second antibiotic can be more effective. So, there's a lot of controversy out there about treating asymptomatic people. I have seen over the last couple of years in the Milwaukee area, we have seen some health settings where they have kind of rolled out a vaginitis panel that includes screening for MGen and anybody who has vaginitis. And then at the health department, we see all the partners to those people who have been diagnosed with MGen. And, that leaves us thinking like, well, the person who had vaginitis, was it because of MGen at all? I mean, did they have yeast? Did they have BV? Was it chlamydia? Was it gonorrhea? Was it trichomonas? Was there something else? But now we have this diagnosis of MGen, and we're seeing the partners saying like, hey, my partner was diagnosed with MGen, I need to be treated. And the question is, are we adding benefit through, prolonged courses of antibiotics, widely in the community? So again, we know many infections are asymptomatic, and the benefits of treatment really might be outweighed by the risk of resistance. In terms of treating sexual contacts, the CDC says for partners of people with symptomatic MGen, you could consider testing and treatment. I think, again, we do know that people who have symptomatic MGen and have a consistent partner who doesn't get treated do have risk for being reinfected. So again, we're often trying to balance, what is the risk of treating. A test of cure really is not recommended at this point if symptoms have resolved. So what are we doing for Mycoplasma genitalium at the Milwaukee Health Department? Several years ago, we had switched from treating non-specific urethritis, so people who presented with dysuria and discharge and who have a negative gram stain in our setting initially. We kind of presume they have chlamydia, and we had switched several years ago from treating with azithromycin to treating standardly with doxycycline. And that is what the current STI guidelines say as well, to start treatment with doxycycline. And now we actually no longer test for MGen routinely at the first visit. We reserve that testing for people who have persistent or recurrent urethritis or cervicitis. And we are also doing MGen testing in people who have PID. Again, the treatment course is doxy plus moxy, and in somebody with PID, you would want them to, often they would complete the initial 2-week treatment, and then if they were still having symptoms, you would add moxifloxacin, or earlier in treatment, if they weren't responding to treatment, you would consider switching to moxifloxacin. And of course, unfortunately, in pregnancy, our options are pretty limited. And at this point, the best we have is a high-dose azithromycin course, which again, in some populations, may fail because of the resistance. All right, so for this question, we send off the MGen testing, which returns positive. It's been 3 weeks since he finished the course of doxycycline. So what are we going to treat with here? We'll take a moment for a quick poll. Great. So if we're able to send for macrolide resistance testing, that would certainly be a reasonable option. Again, there are, I would say at this point, probably very few, but there are a few places where that's a possibility. But for many of our settings, we're going to restart the doxy again and do a whole another week of doxy followed by moxifloxacin. All right. So moving on to EPT.
Okay, so we have a couple of slides to get through, and not much time, but I want to respect everyone's time. So we might just talk through these cases rather than do the polls if that's a possibility. In this case, you see a young woman in clinic. She has male partners, 2 male partners in the last 60 days, inconsistent condom use. She has contraceptive on board with an IUD, and you screen for chlamydia, which comes back positive. So the question is, what do you do? So you want to treat this person, and in the interest of time, I will give you the answer, which is that we also want to offer a script for expedited therapy, expedited partner therapy for her sex partners. So what is expedited partner therapy? So it's the practice of giving treatment to someone to give off to their sex partners, whether it is in the form of pills or whether it is a script that that person can then go on to give their sex partner. In Wisconsin, there is statute and guidelines that allow for the treatment of trichomoniasis specifically, which is not the case across the country. And there are also guidelines for gonorrhea and chlamydia, which are more commonly seen in different states across the country. So what are those treatment recommendations? This is from the Wisconsin Department of Health Services for chlamydia, 100 milligrams doxycycline twice daily for 7 days, or 1 gram of azithromycin, PO. Remembering that 1 gram of azithromycin is still a decent treatment option for chlamydia, even though it is not the preferred option. And there may be cases where it may be easier for a person to take 1 dose of a medicine instead of a 7-day course of medicine. For gonorrhea, the EPT option is 800 milligrams of cefixime in a single dose. And they also recommend for co-treating with chlamydia if that hasn't been excluded. And remember, you're not thinking about the person in front of you, you're thinking about that person's sex partners. So probably the better part of valor may be to offer both treatment options for that person who you aren't seeing directly. And then furthermore, as I mentioned, in Wisconsin, we do have guidelines for the treatment of trichomoniasis. If the sex partner has a vagina, then the option is metronidazole twice daily for 7 days, 500 milligrams. And if the sex partner has a penis, then it's 2 grams of metronidazole in a single dose. Just to highlight a few different nuances of expedited partner therapy guidelines. So doctors, nurse practitioners, PAs can dispense or prescribe a medication for EPT, and pharmacies can dispense medications for EPT. The guideline, the statute does protect people from liability, except in cases of wanton misconduct or negligence. So continuing to use clinical judgment and adhering to local guidelines. The prescription can be written with EPT or expedited partner therapy on the specific prescription, so that the pharmacy can fill it understanding what it is for. And then there are fact sheets that are available from the Department of Health Services website, which the statute says must be given to the patient. And I have pictures of those here. Those are available for downloading on the website. A couple more specifics about EPT here in Wisconsin. So the guidelines say that you can write as many scripts for EPT as needed, thinking about how many sex partners the patient has had in the last 60 days. So if the patient has had 2 partners in the last 60 days, you can write 2. If they've had 5, you can write 5. There's not kind of a maximum limit that is described in the statute for how many scripts you can give. They do specify in their guidelines that no EPT should be given for syphilis. There's a lot of nuance, as we talked about earlier, in the diagnosis and treatment of syphilis. So this really should be done by referring the sex partner to their own clinician for an evaluation. For female sex partners, the guidelines state that we can give EPT, but to use caution. And there's a number of reasons for this. Female sex partners may be pregnant. Female sex partners could have co-infection, and female sex partners could have pelvic inflammatory disease. And so all of these are reasons to kind of have some caution. So if you hear that someone wasn't using condoms and you worried that pregnancy is a possibility, maybe the sex partner didn't have contraception, well, that might be a reason that you would recommend that person get a screening and evaluation independently. Furthermore, there is a bit of equipoise in the literature. There's a bit of ambiguity in the literature around, and I would say in clinical practice too, around what to do with men who have sex with men. There is a little bit of lack of proven efficacy in the MSM community about the efficacy of expedited partner therapy. And so the guidelines sort of say that it should be a shared decision-making decision. If you have a man in front of you who has sex with men, you should talk with him, and you could offer an expedited partner therapy script, but you may also want to say, well, that person really should get their own risk evaluation and see a provider. MSM also have higher rates of HIV, and so that may be a reason for that person to seek their own testing and evaluation. So with EPT, again, we're just really re-emphasizing that it is a really good option. It's a good option to help reduce the risk of reinfection, but it's always recommended to use clinical judgment when assessing someone's candidacy for EPT. And you do need to use your own judgment of the person in front of you. If there are any doubts, then you can always refer that person to their own independent evaluation. Of course, all the other STI treatment basics and counseling still apply. Make sure that people are using barrier methods until they have cleared. If a test of cure is indicated, then that would be recommended as well. And if something is a reportable disease, then we want to report it. EPT is also reportable. We have some cases here. Go ahead.
Yeah, I was just going to say, Laurence, maybe just to emphasize as we get to the end of our time here is that, one thing to think about with EPT, specifically for gonorrhea is, has the patient's partner had oral exposure to gonorrhea? Because again, cefixime is going to be less effective at treating oropharyngeal gonorrhea. So if you are thinking about EPT for a partner to gonorrhea and that person has oropharyngeal exposure, again, really the best treatment would be to have that person to be evaluated and receive ceftriaxone injection.
And then we're coming up on time. I'll just talk through these cases very quickly. So this case, this is a cisgender male who presents with some symptoms. He tells you he has a cisgender female partner, and that partner has had some abdominal cramping in the last week. His gonorrhea test is positive. What do you do? And Our suggested answer would be to recommend the sex partner seek immediate care for testing and treatment. So the abdominal cramping is pretty concerning. That person really should get an independent evaluation by their physician. The next case that we
I think we
that's
cut it short.
Yeah,
Yeah.
we cut it short. Yeah.
Yeah, so just summarizing, there's some great clinical resources out there. So for those of you not aware, the clinical consultation services is a online, you can submit questions, you get a CDC consultant responding usually quite quickly within a day or so to like those difficult questions, especially around syphilis. There's some great additional CME that's available. And again, the Wisconsin DHS has an STI unit with some forthcoming and updated web pages on drug-resistant gonorrhea, which we hit on today. So these were kind of the main references that we had today. So we would be happy to take a few minutes for questions.
Wonderful. Thank you all so much. If anyone has questions, put them in the chat. I've already gotten a few just sent to me, so we can start with those. One question is, do people mistake secondary syphilis rash for Mpox? Is that something that you see?
That's a great question. I feel like I had seen more concerns with chancres and Mpox. And I think that I definitely heard when there previously was more cases of Mpox that we were seeing, I had heard cases from very experienced public health STI nurses saying like, it looked like a chancre, but I did swab it for Mpox and it came back Mpox. So, I would say primary syphilis and Mpox, I think was more common as opposed to, I haven't heard as many cases of confusion with secondary syphilis, but, potentially.
Okay, good to know. Another question, and this could be, I know people have a lot of opinions about this, but should our clinic consider DoxyPEP? How are y'all feeling about that at this point?
That's going to be like a primer for our next webinar on STI care in special populations. But yeah, do you want to take that one, Laurence?
I would say that the initial literature among men who have sex with men and transgender women is very promising for DoxyPEP, for the efficacy of DoxyPEP. There are not national guidelines, but the CDC does right now have an open period for public comment on guidelines that it is proposing. So there may soon be national guidelines about DoxyPEP. The SF City Clinic, San Francisco City Clinic, and the California Department of Public Health do both have guidelines, and the SF City Clinic also has handouts, which are in PDF form, which you can give to patients. So I think if you have MSM or transgender women who are on HIV PrEP or who live with HIV, it's a proven thing that can keep them safe and can prevent STI in those populations. So I would say yes, I'm a big proponent of it, but the science is still evolving, guidelines are still evolving, and so each location really needs to tailor it to their patients and the epidemiology that they're seeing in their community, I'd say.
Yeah, and I think as an important caveat to that is that unfortunately the science really isn't showing efficacy for DoxyPEP in women. So those trials, unfortunately, again, this is like the population again is really men who have sex with men or transgender women who, and especially those who have had an STI in the past year.
Okay, that's good. And we'll look forward to hearing more about diving into that specifically in our next webinar, which is actually, if you wouldn't mind switching the slide. The next one is on the 14th, Tuesday, the 14th of November. That event announcement already went out, but if you didn't get it, or if you want another copy, just shoot me an email, awhite@hcet.org. Also, if you reply to the updates email for all the things that HCET sends you, someone will get that to me too, but awhite@hcet.org to make sure you get that invite if you haven't already. I want to be respectful of everybody's time. I know that you both have patients after this. Thank you so much for taking the time to give us all this information. And we're excited for all of you to hopefully join us for the last webinar in this series on the 14th of November. Thank you so much.
Thank you.
Thanks.